So welcome and good evening, and thank you for everyone to take time this evening to join us for this webinar session entitled Oral Antibiotic Treatment for Prosthetic Joint Infections. This is a joint venture of the Canadian Orthopedic Association with the Association for Medical Microbiologists and Infectious Disease Canada. My name is Dr. Gavin Wood. I'm an Associate Professor of Orthopaedics at Queen's University in Kingston, Ontario. I'm currently the chair for the Standards Committee for the Canadian Orthopedic Association, and I'm also the president-elect for the Canadian Arthroplasty Society, a subspecialty association within the COA. I'd also like to just take a minute to thank the faculty who are named here with helping out with tonight's discussion. First up after me will be Dr. George Grammatopoulos. He's a friend and colleague of mine. He's an associate professor of orthopedics in Ottawa. His specialty area is primary and revision arthroplasty, and he has a particular interest in dealing with periprosthetic joint infections, which is his mainstay of his clinical work and his research focus. We also have Dr. Marie-Philly Granger, an infectious diseases and medical microbiologist specialist affiliated with Sherbrooke University Hospital. She also completed a fellowship in antimicrobial stewardship at Sunnybrook Health Sciences Centre in Toronto and a certificate in quality improvement and patient safety at the University of Toronto. And we also have Dr. Philip Lamb, who's an infectious diseases consultant at Sunnybrook Health Sciences Centre, assistant professor with the University of Toronto. He is the medical director for the antimicrobial stewardship program at Sunnybrook. His research interests are focused on using quality improvement methodology to develop sustainable health interventions to improve the appropriate use of antibiotics. So again, thank you, and thank you to my colleagues. We move to the next slide. Before starting, I wish to acknowledge the traditional Indigenous territories that we all reside in and are represented across Canada this evening. And we give thanks to honouring this great land that we all share. Next slide. Just some housekeeping notes. Please use the Q&A feature in the chat. Questions will be discussed at the end of the presentation. We do have interactive polls during the presentation, and I encourage you to answer as we go through. This will also help our presenters. This session is accredited, it's being recorded, and it will be available for viewing on the media stated. We'll go to our next slide. So tonight's objectives. First, we hope you enjoy this session and that you'll learn something new and take something away for your practice. This webinar was produced to primarily focus and explain our new combined position statement between our associations on the use of oral antibiotics in periprosthetic joint infection. Next slide. Again, these are our evening's speakers and their conflict of interest. And if we move forward, so just to quickly outline how this evening's going to go, we're going to have a case presentation, and then following that, we're going to go through quickly the process that we went through in order to come to this joint statement. And then we're going to go through and over the results of a national survey that were distributed to both our associations and the respective results from those two groups. Then we're going to hear from Dr. Philip Lamb on his experience in Toronto with the use of oral antibiotics since they changed their practice. And then we'll have a conclusion on the case presentation at the end, followed by some question and answer and discussion session. Next slide. So at this point, I'd like to hand over to my good friend, George Grammatopoulos, to present us with this case. Thank you, George.
Thank you, Gavin. Thank you for the introduction. So this is a 64-year-old gentleman that we treated here in Ottawa. He has a history of diabetes, coronary artery disease, dyslipidemia, and he had a right total knee replacement about 4 years ago. He presented to the emergency department with a 3-year history of right knee pain, fevers. He had right knee swelling as well, and he had pain with ambulation. Clinically, when seen, his right knee was swollen, erythematous, painful on palpation, and he had a reduced range of movement from 10 degrees of flexion to 80 degrees of flexion. At the time, he remained hemodynamically stable. And in the emergency department, he had a joint aspirate, which had a high white cell count and 85% neutrophils. And cultures were pending, although no organisms were seen. His blood and inflammatory markers were elevated with a CRP of 256 and an ESR of 56, and blood and urine cultures were drawn. On day one, he was taken to the operating room. He had an incision and drainage, extensive synovectomy, and he had a first stage revision where we removed the original implants and inserted a femoral stem and an all poly tibia with a Steinman pin. Postoperatively, he was started on IV ceftriaxone and vancomycin on broad spectrum as per our protocol. Thereafter, his blood cultures started growing gram-negative bacilli. And we'd like to start this session with a few questions. Question number one, how many operative samples would you send amongst the surgeons or amongst ID physicians? How many samples would you expect to receive for analysis? Thank you. We'll move over to the next question. Would you have performed first stage revision, or would you have expected for the orthopedic team to have performed a first stage revision? Bit of a split in the approach here. Question number 3. Should surgery be performed by an arthroplasty surgeon or whoever is on call at the time? Okay, more consensus here on this one. And would you order a PICC line straight after the OR? Thank you. Once again, a bit split here. So I'll take you back to the case now. On day 2, blood cultures and the joint aspirate culture was positive for Pseudomonas. IV antibiotics now changed to piperacillin and tazobactam with the dose as seen on the slide. He remained in hospital for the next 2 days with no significant changes. He was systemically and overall well, mobilizing accordingly. On day 4, his OR cultures, there were 4 samples taken. All were positive for Pseudomonas once again. And susceptibilities were available, and he was susceptible to ciprofloxacin, piperacillin, tazobactam, and ceftazidime. Patient was recovering well from surgery at that stage. So we'll go back to the questions. Once again, would you be comfortable transitioning this patient to highly bioavailable oral antibiotic therapy to complete the remainder of the treatment course? Okay, that is very interesting to see. When would you switch the patient to oral treatment? A bit more of a divide here. Just make a note of this. That's great. Having switched to oral therapy, are you comfortable to send the patient home the same day? And I suspect that would imply specifically to the first two groups that answered within the first week from the question before. And when would you follow a patient like this in clinic? Within 2 weeks, 4 weeks, or 6 weeks? Thank you. I'll pass on to the microphone to Dr. Wood once again.
Thank you, George. So we're just quickly going to go over how we got to this joint statement. So as I said, this was work basically from both our associations. This was brought to the table by our colleagues on the microbiology side, excuse me, and then working closely with them, we kind of came to a joint statement. We have an evidence-based research group who reviews and checks and cross-references all the literature on our position statements. And in combination with them and the AMMI, we then came up with a proposed statement. We then did our practice survey to get some feedback, to give us some ideas on any potential amendments to that in order for clarification, and then went through a kind of a public before patient representative before actually going to final endorsement. So there's certainly been growing evidence in recent years demonstrating that oral antibiotic is non-inferior to IV for the treatment of prosthetic joint infections. This is one of the major multi-center non-inferior randomized control trials, which had a large number. Patients with bone and joint infection who received at least 7 days of IV therapy from definitive surgery were then randomized to either oral or IV therapy for the remainder of that course. And with the primary outcome, the definitive treatment being failure within 1 year after randomization, essentially there was no difference. So the intention to treat analysis confirmed non-inferior of oral therapy. Next. And of course, we're well aware of the advantages of using oral antibiotic therapy. We can reduce the length of hospital admission. This not only has financial benefits for the institutions, but also the benefit for the patient that they're not in hospital for any prolonged length of time and they get within the comforts of their own home. Many patients also don't like having the PICC line catheters and the associations of having blockages, infections, and then just carrying this around for a period of time. They'll often liken it to carrying around a friend, as I've had some patients say, for a period of time. So it certainly increases the quality of a patient in not being tied to those PICC lines and having them home for as much as possible. Next slide. So the joint statement, these are our recommendations. Essentially, highly bioavailable antibiotics can be used as first-line treatment for bone and joint infections, and this includes prosthetic joint infections. And this is in collaboration with co-management with infectious disease specialists if the following criteria are met. So the patient has undergone appropriate source control, in other words, washout, debridement, explant, etc. If the pathogen has been isolated, that is confirmed to be susceptible to those bioavailable oral agents, and that there's no other focus of infection which requires IV antibiotic that has been identified. In other words, making sure there are no other potential sources of infection. The patient has to have a functioning GI tract, which makes sense if you're going to absorb oral antibiotic, and that there's no allergy or drug interactions with any other medications that the patient is currently on. The patient is also expected to be able to adhere to the oral antibiotic regime and be compliant, and also able to afford the 6 to 12 week course of oral antibiotic therapy. So oral antibiotic therapy can be started as soon as the patient is able to tolerate oral medication and their GI tract is functioning well. Culture negative infections can be treated with highly bioavailable oral antibiotic combinations if there is no concern for resistant organisms or non-bacterial infection. Next. So, having come up with a rough statement that we wanted to go ahead with, in order to make sure we weren't missing anything, we sent out invitations to our members to answer a national survey. And these are specialty specific questions with case vignettes. And we had 51 survey respondents overall, and we had 21 from the orthopedic community, and 28 from the infectious diseases community, and 2 from microbiology. Next. First, I'm going to go through the results from the orthopedic surgical cohort. So we had 21 orthopedic surgery respondents. The median periprosthetic joint infections that they co-managed annually was 14.5. And the vast majority of those treating those infections, 81%, were practicing in an academic setting. What percentage of prosthetic joint infections that you co-manage are treated with oral antibiotic therapy for the majority or full duration of the treatment? So about 10%, and there was only 15 respondents. So of the 21 respondents, 6 choose not to comment. And what proportion of cases of prosthetic joint infection do you seek an infectious diseases consultation on? And all surgeons look to seek for consultation. Can I just stop there for a second? Just go back. George, any comments on those first couple of questions? If we go back one slide, the number of periprosthetic joint infections, 14.5. Do you think that's a low number? Do you think that's a high number? And then any comment on the spread of the experience, perhaps, of the orthopedic surgeons we surveyed?
Thank you, Gavin. That's interesting. I think definitely in an academic setting, and especially in a setting that draws cases, PJI cases from sort of the region, I would say that we probably all the members of the PJI surgical group probably manage 3 to 4 cases a month, and therefore I would say that annually our numbers would be a significant order of magnitude greater than the 14.5 that's reported, and that's probably in line with what the Canadian Joint Registry would portray with about 9,000 revision arthroplasties reported per year, and a third of them being for PGI, which means we probably do about at least 3,000 PGI related revisions per year. So I think sort of 1 per month per surgeon or thereabouts, especially when most of the surgeons are from an academic center and they are in sort of their in very productive years of their practice, is probably low in terms of what I would have expected.
Okay, thank you. And what do you think of the 10%? If you go to the next slide, please.
Yes, this is interesting because in the previous question of the interactive amongst our the group that's joined tonight, they were comfortable to transitioning to oral antibiotics in that case vignette in 76% of the cases. So that's a very interesting transition. And I wonder whether that very low number reflects perhaps some historic attitudes of the acute postoperative period being associated with a long duration of IV antibiotics, and perhaps that period, the acute period, being considered the majority of the duration of treatment. Perhaps these 2 factors are at play.
So if we keep that in mind, if we go to the next slide. So how comfortable are you with oral antibiotic therapy being recommended by infectious disease specialists for the treatment of prosthetic joint infections, was the question. And if you look at the responses here, not comfortable and somewhat comfortable seem to make up the majority of the respondents, and only a smaller number are very comfortable. Any comments on that, George?
Mm. I think this is likely to be a reflective of a historic perspective amongst the orthopedic books and what sort of our traditional teaching has been of IV antibiotics for the duration of treatment. So I think there's now high-level data to suggest otherwise. And as we are in more and more communication with our ID colleagues and we learn more about the available data and the sort of pharmacokinetics, I think as orthopedic surgeons will become more we will shift hopefully towards the right part of this bar graph towards being more comfortable with greater education and sessions like today. So I think this is more historic in what our traditional books say.
And that would probably go with perhaps some of the ones that are a bit longer in the survey where they've been in practice for a lot longer. They maybe just practice more kind of traditional type IV antibiotics as opposed to oral, and they're perhaps just a little bit behind some of the more modern aspects of treatment that we're discussing here this
Mhm.
evening. So if we move to the next slide. So here are some of the case cases that we might be expected to treat. So we've got first episode, right knee prosthetic joint infection treated with a DARE, MSSA. And then first episode treated with a stage 1 of 2 revision for MSSA. And then moving forward to another episode, 1 of 2 stage where it's culture negative. And as we're moving from left to right, there's more surgery involved in treating those cases. In other words, there's kind of minimal surgical intervention in the first one, and then that increases as we go through. And there seems to be somewhat of a shift from not comfortable at all with oral antibiotics to one side and then comfortable with the other. Does that follow what we were talking about before, or any comments there, George?
I think once again that's an interesting observation because the case vignette falls in the middle, and most of the participants were happy to transition to oral antibiotics. What is interesting, however, is that um, perhaps this reflects to what picture the participants had as part of the degree of the PGI they were treated. Perhaps a DARE was considered to be not a significant PGI, or could it have been a PGI? However, so I can sort of understand the thinking. From a surgical point of view, the more extensive the surgery, the more likely there has been a good surgical reduction, if not elimination, if elimination is ever possible, of sort of the infected load. And therefore, I would probably be happier or more confident or more comfortable with oral antibiotics with a first of two-stage revisions or a single-stage revision where the infected overload has been significantly reduced. That would be my personal approach. And I think that the responses might be related to the extent of PGI as part of the selection made by the surgeon at the time of surgery.
Okay, thank you. Next slide. So again, this is as we get into more complexity with these cases. So first episode of left hip PGI treated with single stage revision, a different organism, and then another recurrent infection who's already had a one stage is going for a repeat one stage. And then again, first episode, right knee joint infection, but this time with perhaps a more resistant antibiotic, MRSA. And you can see that they're becoming less comfortable with oral antibiotic again as these cases become more complex in nature or the organism becomes perhaps more problematic. Does that kind of follow what you would expect then from the previous question and answer on the survey?
I think again that's not what our polls would show from today, and it's perhaps similar to the observation from the previous slide. So hopefully the opinions would change as part of the by the end of the webinar.
Perhaps most of the ones that are on this evening are actually from the AMMI group as opposed to the COA group.
Mhm.
Next slide, please. So in what clinical situations do you prefer the use of IV antibiotics for majority or full duration for the treatment of prosthetic joint infection? And this is for the orthopedic group. And essentially, this just kind of summarizes what we've seen in the previous slides, where we're going from a kind of a DARE procedure through to much more complicated and involved surgery with various types of organisms. And you can see that the orthopedic surgeons are becoming less and less comfortable with oral and are pretty much moving to IV for the full duration of treatment. So that kind of concludes the orthopedic results on this survey. So I'm going to hand over now to our microbiology colleagues to discuss the results from their national survey. Thanks.
Thanks, Dr. Witt. So I'm going to go over the next section, which is looking at the ID and microbiology respondents to the same survey. So we had about 30 respondents, and respondents reported co-managing a median of 24 prosthetic joint infections per year, with 2/3 of these respondents practicing in an academic center. This was a specialty-specific question asking about comfort level in using different highly bioavailable oral antibiotics for the treatment of prosthetic joint infections. And I've kind of ranked them here from the top, those that are the most comfortable, to the bottom, those that are least comfortable. So you can appreciate that things like doxycycline, fluoroquinolones, and trimethoprim sulfa, respondents were very comfortable using these. And then we have kind of in the middle, we have some oral beta-lactams, so amoxicillin, cephalexin, and amoxiclav. And then at the bottom, linezolid and clindamycin, suspect either related to the side effect profile or potentially financial considerations. And this reflects well in terms of the evidence. For example, in the OVIVA trial, fluoroquinolone and trimethoprim sulfa were the most prescribed oral antibiotics in that RCT. We asked also when they felt most comfortable transitioning to oral therapy and what was the minimum number of days that they wanted to treat with IV antibiotics. The median response was 7 days with a range of 5 to 14. These are the same case vignettes that Dr. Wood described earlier. Again, these are the first three. You can appreciate that overall the numbers in terms of comfort are a bit higher. But certainly what's interesting here is the third vignette, which is an episode of prosthetic joint infection that's culture negative. ID and micro-respondents were less comfortable treating with oral antibiotics, which is interesting. These are the last three case vignettes, again, looking at an episode that's a single-stage revision due to Cutibacterium, a recurrent prosthetic joint infection due to MSSA, and then one episode due to MRSA. You again can appreciate in certain scenarios there's a bit less comfort in prescribing oral antibiotics. This is the same question that was posed to both orthopedics and ID. I've now kind of laid them out side by side so you can compare the relative frequency of responses between orthopedics and ID and microbiology. And what's interesting is that there are some differences in terms of situations where specialists are preferring IV over oral. I think most interesting from an ID standpoint is that ID and microbiology are much less comfortable prescribing oral antibiotics in culture-negative prosthetic joint infections. Conversely, as Dr. Wood and Dr. Grammatopoulos mentioned, in this survey, infections due to more drug-resistant organisms, the orthopedic group was less comfortable with prescribing oral antibiotics. So just a few survey observations. So as Dr. Wood and Grammatopoulos had mentioned, there was some discomfort of using some oral antibiotics for multi-drug resistant organisms, and those are the history of prosthetic joint infections. We know that the efficacy of oral antibiotic therapy is largely dependent on its ability to concentrate well at the site, so the bone in the joint. The highly bioavailable oral antibiotics that are prescribed are, like I said, highly bioavailable, meaning that the degree to which it is absorbed in the bloodstream and hence penetrating into the bone and joint is largely equal, regardless of whether you give it intravenously or orally. And we have good evidence to show that these highly bioavailable oral agents that I described earlier have good bone and joint penetration. There's no evidence out there to suggest that oral therapy is inferior in patients with PJIs due to multi-drug resistant bacteria or those with a history of prosthetic joint infection. From the ID side, there was certainly some discomfort in using oral antibiotic therapy for culture-negative prosthetic joint infections. And historically, regimens such as ceftriaxone and vancomycin intravenously would commonly be used in the treatment for culture-negative PJI. One strategy that we've used locally to help drive practice change is actually developing a WISCA, or a weighted incidence syndromic combination antibiogram. Essentially, you're basically looking at combinations of antibiotics and seeing whether the collection of bacteria are susceptible. And these are weighted based on the relative frequency of the organisms that are isolated within that cohort. And so one of the ID fellows, Dr. Dhaliwal at Toronto, one of his projects that he worked on at Sunnybrook was actually creating a WISCA using 7 years of prosthetic joint infection data, which was 410 bacterial isolates from 288 cases of prosthetic joint infections. So by creating this weighted incidence syndromic combination antibiogram, we were able to plot out which regimens would be comparable to something like ceftriaxone and vancomycin, which has to be given intravenously. And what we found was a combination such as moxifloxacin and doxycycline together provided comparable likelihood of antimicrobial coverage. So I hope this information is helpful in supporting ID physicians and microbiologists in coming up with combination regimens that are oral, even in cases where cultures are negative. I want to move on just to our experience at Sunnybrook, where we launched a quality improvement initiative aimed at improving the use of highly bioavailable oral antibiotic therapy. This was a collaboration between ID, microbiology, and orthopedic surgery. And this was implemented about 3 years ago. We encounter approximately 60 prosthetic joint infections per year, and all these are co-managed between orthopedic surgery and infectious diseases. In terms of carving out a pathway, there are really 2 major changes that we implemented. The first one was around deferring peripherally inserted central catheter insertion until we absolutely knew that this patient needed intravenous antibiotic therapy. Often this was done earlier in the admission to help streamline their hospitalization and to basically shorten their length of stay. But knowing that a large majority of patients will be amenable to oral antibiotic therapy, we didn't want to basically have patients undergo a procedure that was unnecessary. We also encouraged ID involvement as early as possible so that we could liaise with the microbiology lab to ensure that the appropriate oral agent susceptibility results could be tested. And so within the 6 ID physicians at our institution, we all kind of agreed to start shifting our practice to transition patients early to highly bioavailable oral options based on culture results. If we were still waiting for culture results and the patient was ready to go home, we would not delay discharge just to wait for cultures, but we'd actually discharge them either on a peripheral IV with empirical IV antibiotics or transition them to a combination regimen, as I discussed earlier, something like moxifloxacin and doxycycline together, and then follow them up basically in a week's time to help tailor their therapy based on any pending culture results. Of course, we want to make sure that safety was our priority here to make sure that patients were not encountering harm. And so we counseled our patients very extensively, making sure that these patients were the best ones to benefit from oral antibiotic therapy. We had a close clinic follow-up, and we reviewed data on a monthly basis to make sure that we were seeing uptake. So this is our outcome measure. On the y-axis are the proportion of PJI cases treated with oral antibiotic therapy by day 7. And on the x-axis is essentially quarters in the year. So the first 4 data points are in 2021 prior to implementation, and then implementation took place in February 2022. So you can appreciate that with implementation, we've seen an uptake in the use of oral antibiotic therapy transition by day 7. And when we study this as a cohort from February 1st, 2022 to July of last year, 66 out of 140 PGIs, which is around 50%, were transitioned to oral therapy by day 7. In terms of safety measures, we obviously want to make sure that these patients are not sticking around in hospital longer than necessary. So we looked at the length of stay in 2021 in all patients with PGIs and compared it to those treated 2022 onwards with oral antibiotics and found that the length of stay was really no different. In the 66 cases that were treated orally, there were only 5 cases of treatment failure, 7.5%, which is quite excellent and comparable to the literature. No patients were lost to follow-up with excellent adherence to therapy. The most common side effect was gastrointestinal. No financial barriers to procuring oral antibiotics were encountered. So I'm going to pass it on to Dr. Ganger, who's going to talk a bit more about the cohort that we actually treated with oral antibiotics.
Thanks, Phil. So yeah, so following that initiative at Sunnybrook, we wanted to understand the factors influencing oral versus IV therapy for first episode PGI, and to see if we can address those factors to increase the oral treatment for PGI. So we did a retrospective chart review in our center in Sunnybrook of all first episode of PGI between February 2022 and January 2024. And we were looking, oh, sorry, can you go back? And yeah, thank you. So, and we were looking at the chart for the reason why prescriber chose IV instead of oral. Therapy wasn't that clear in the chart. Then we interviewed the prescribers, so we don't have any missed information. So we had 678 total first episode PGI. 44 were treated orally and 34 were treated intravenously. So here are the main characteristics of the two groups, which are quite similar. Majority of the infection were hip and knee infection, and the majority also had first stage or there as a surgical management. Next. So about the main pathogen isolated, the majority were coagulase negative staphylococci, followed by MSSA and QT bacterium species. There was really few MRSA identified, and culture negative infection represented around 10% of the entire cohort. Next. So here are the antibiotics used. So the majority of the PGI treated orally were treated with either doxycycline or quinolones. There was really few oral penicillin and cephalosporin used, and also few rifampicin in combination. Next. So here are the reason prescribers chose IV therapy over oral. So the main one was negative culture. So that's kind of represent what the survey told us too. Second was concomitant infection necessitating IV antibiotics, and followed by delay in obtaining susceptibility results. We didn't identify anyone in particular who consistently preferred IV over oral. So like an individual preference wasn't that an issue here. And so as you can see, there's some of those barriers are not avoidable, such as concomitant infection necessitating IV antibiotics, or intolerance or resistant bacteria without any oral choice. But all the other ones are avoidable. And if we address those, we estimate that we can increase the oral treatment of PGI to 50 to 60%. Next. So how can we do that? How can we increase the comfort? So the the most important things would be to have a good partnership between orthopedic surgeon and ID specialist and microbiologist, and an early involvement of ID specialists in those cases. as an ID specialist, we can help you add work lab early on for the isolate, such as susceptibility testing for oral agent. So you would receive that information quicker. Also, we can suggest rapidly an oral agent and differing the installation of the PICC line and probably complication associated with the catheter. Another way to reduce the delay in obtaining susceptibility reports for oral agent would be to work with the micro lab and microbiologists to validate and add susceptibility testing for oral agent on the first line antibiogram panel for bone and joint specimen. So that needs also a good partnership with microbiologists and the micro lab. As we saw previously in the survey, but that's also what we saw in our local study, and also that's represented in the literature. So there's a concern for treating culture negative infection with IV antibiotics, probably because of the fear of missing the target with IV. But as Philip told us, there's usually a good combination of oral agent that would cover the same pathogen as an IV combination. So in order to choose that right combination, I have to review local epidemiology. So what are the principal pathogen causing PJI in your institution? And also what are the usual susceptibility of those bacteria. If you have a stewardship program in your institution, that's something that they can help you with. Another really important thing to understand is that ensuring adequate number of intraoperative specimens sent to the micro lab will reduce the risk of having culture negative infection. So we are talking about 3 to 5 adequate specimen. So an adequate specimen would be tissue or biopsy. Liquid specimen is an alternative, but please try to avoid swab because those are really less sensitive unless you don't have any other option. Of notice, you probably know that we focus our work on first episode PGI only. That was our low-hanging fruit. We felt that in order for prescriber and so for clinician to gain comfort in that new practice change, we wanted to focus on that first episode, and eventually with getting more comfort, then probably recurrent episode would be also treated orally. But in the literature, there's no really different in the management between first or recurrent episode. So next. So to conclude the case, it was I think it was a 64 years old man with a history of diabetes, CAD, dyslipidemia, admitted with bacteremia and right knee prosthetic joint infection due to Pseudomonas aeruginosa. So he was transitioned to oral ciprofloxacin 750 milligram orally twice on day 5 and completed a 12-week treatment duration with regular follow-up with ortho and ID with minimal side effect. And he has been off antibiotics for 15 months, remain infection-free since. Next. So just a wrap up of the objective that were to summarize the recommendation of AMMI Canada COA Joint Statement on oral antibiotic treatment for bone and joint infection, to describe the national practice pattern in the antibiotic management of prosthetic joint infection and to identify strategies to improve the uptake of oral antibiotic use in the management of prosthetic joint infections.
Thank you.
Thank
Can we pull up we've got a little bit of time. Can we pull up the poll results from the questions that we had earlier with the case presentation? I just want to touch on a few things and maybe ask some of the panel. So yeah, question one, how many operative samples would you send? I think for the most part, everyone's agreeable. You're probably looking at 5 samples, which you mentioned in your presentation. And I always try to take at least 5 myself. And I always want to finish on an odd number, just so that if you get something back from microbiology, it's not 2 against 2 or 4 against 4, that there's always a winner with an odd number. George, you do a lot of these types of cases. Do you have a minimal number of samples? And then any comments on the fluid sample as opposed to tissue sample?
Minimum 6 is sort of my number, but I like your odd rule, so I might adopt it. But for me, it's minimum 6. That was sort of part of our traditional training. But we have stopped swabs, so I really liked Marie's comment. It's something I wanted to raise. We want proper samples and fluid from the joint, but no swabs. So that's something that we have tried to instigate as part of standardizing practice in our center.
So I want to ask you that because for the most part, I take soft tissue samples, but when I'm operating, and often the first thing I do when I get into the joint is you often get this initial gush of fluid or pus. And I often think if I get a really kind of clean sample catch, whether that's actually worth doing. But would you say that that's just tradition and me kind of following old suit, or do you think that first gush of fluid that comes out might be advantageous? Any thoughts from either side of the fence here?
So I would always start with a number of syringes and needles so that before I open any fascial plane, the syringe goes through. So to decompress and also make sure that there's not too much splashing, but also I suspect it has a high yield. I cannot comment about the yield. I will let the other members of the panel discuss, but I would agree that this is valuable fluid prior to the gush.
Any thoughts from the other side of the fence? Nope. Okay. Can we go on to question number 2? So would you have explanted the hardware? It's kind of a bit of a split here, and I don't know how many surgeons against physicians are on here. Certainly there's, and when you look at the question 3, if we just quickly go to question 3, because they're kind of tied in. Should surgery be performed by an arthroplasty surgeon? And so I agree that an arthroplasty surgeon should probably be the main decision-making individual from a surgical perspective when dealing with periprosthetic joint infection. However, depending on your institution and who's on call, you might often find that it's a non-arthroplasty surgeon that's on call and the patient's unwell and the patient needs to go because they're hemodynamically unstable to operating much more quickly. And then in those instances, there's been a new term thrown out there, which is a double dare. In other words, a patient comes in acutely, they get that initial debridement and implant retention, but then within a week, they should come back and have a much more definitive procedure, probably by an arthroplasty surgeon. And I think that's a way of trying to kind of cover this acute treatment followed by the appropriate treatment. Because I know there's also some work out there as well where a delay to getting that initial washout and debridement can often affect the overall outcome long term as to whether you can actually eradicate an acute infection over a chronic one. Any questions or comments by the rest of the panel on my thoughts there?
Thank you, Gavin. This is work that we did here in Ottawa, led by Dr. Garceau, that delayed surgery more than 36 hours from presentation is associated with significant reduction in the success of any PGI procedure. So I would be in favor of these cases being prioritized to an extent. And we also done some work to show that surgery led by arthroplasty surgeons have greater chance of success. Also with DARES, the late hematogenous don't do as well as the acute postoperative. So these are three factors to consider as part of the decision making for this case. These are my three thoughts. Thank you.
Thank you. Can we move to the next question? And this is with regards to PICC insertion. And I think this was touched upon in the discussion. For logistic purposes, it can often be a while for us to get a PICC line, and often we put in a referral early just to streamline the patient kind of getting this done in home. But I think it's a good point where you don't want to be doing inappropriate procedures with potential complications, and if they're going to be switched to oral. And so this is a learning point for me from this evening's webinar is perhaps just to take a little bit more time to wait until these cultures come back and not try to be so quick to get a PICC line. But again, it varies from institution to institution. As I said, sometimes it can be quite a process getting a PICC line. If we move to question number 5. Would you be comfortable transitioning this patient to highly bioavailable oral antibiotic? So that most of the people on tonight said yes, but the survey results would kind of contradict that, and that's why I thought perhaps most of the people on this evening are already transitioned to newer thoughts around periprosthetic joint infection, or there's more physicians on here this evening. And we move to number 6. When would you switch the patient to oral therapy? Again, I think from tonight, what I've learned from tonight is I think once you know that you've got an oral antibiotic that's highly bioavailable and with the sensitivities, no infections, I don't think delaying putting the patient on an oral antibiotic and sending the patient home is really going to make much difference. So I'd like to thank the contributors to this evening for already changing this older surgeon's perspective on how to treat these infections. If we can move to number 7. Yeah, so same day, just as I commented on, and then number 8. Yes, I think acute follow-up is important. For me as a surgeon, and I'm not sure about you, George, I always like to see that the wound's actually healing at 2 weeks. It can often be an indicator that you've done a good initial debridement or reduction of biofilm, and that perhaps your antibiotic regime is working and that you're kind of ahead of the game or on track for beating this infection. I think often if you've got ongoing drainage beyond 2 weeks, that's often a concern that I have. Any comments, George?
Really agree with that observation.
Okay. If we go to some of the Q&As, just to answer them, one of them was, what is the number of orthopedic surgeons in Canada and how do you explain the low number? There are a lot of orthopedic surgeons in Canada, and that was a low number, which I was a little bit disappointed in. It's difficult sometimes for us to get our members to complete surveys. Often we sometimes swamp them with too many surveys and they get exhaustion from surveys. So we're trying to kind of reduce and target in that regard. However, I think the ones that did respond, I would say were probably reflective of the overall orthopedic community. Would you agree, George, or disagree?
There was a large number of academic centers. It will be interesting to see, surgeons from academic centers. It will be interesting to see from Canadian registry how many revisions take place in academic centers and how many are not. And perhaps there were not enough surgeons within the first 5 years of practice who I'm also dealing with a lot of cases in emergency. So perhaps some of the answers were a little bit skewed towards the more senior surgeons, according to that initial graph that you showed.
Okay, more of a kind of traditional approach to periprosthetic joint infection. Okay, so I'm just going to go through some of these. What is the definition of highly bioavailability? Is there a focus on bone and joint available specifically? I'd like to put that to our microbiologists and physicians to comment upon.
Sure, I can start. So really the idea behind, something that's highly orally bioavailable is the degree to which, the drug is able to establish a concentration in the bloodstream is comparable to that if it's given the same dose intravenously. So an example would be, a fluoroquinolone like levofloxacin, where essentially there's 99% oral bioavailability, meaning that 99% of the dose when given orally is absorbed and basically distributed to the bloodstream. We then have a lot of data looking at antibiotic penetration into bone and joint tissue. So there are many studies looking at a single dose or multiple dose patients undergoing arthroplasty. They take a biopsy of a bone or synovial fluid and they measure the concentration of that antibiotic in there. And comparing that concentration with the known minimum inhibitory concentration of that antibiotic in order to kill a bacteria, there's data to show that these antibiotics actually establish levels high enough to inhibit bacterial growth. And so it's kind of that combination of getting into the bloodstream and then the data showing that it actually penetrates bone and joint.
And just a follow-on question, so that bioavailability within the bloodstream, at what kind of percentage cutoff would you say that perhaps it's not highly bioavailable? Is it like 75%, 70, 80%? When you look at some of these antibiotics.
So I think generally speaking, 80% and higher, I'd probably consider as highly orally bioavailable. Most of them that we prescribe are probably 90% and over. There's maybe one or two that are maybe 80 to 90%.
Okay.
If you're looking at things like quinolones or Septra, like that's the trimethoprim sulfamethoxazole, it's over 90% bioavailability. Doxycycline is also over 90%. But you have also some beta-lactams such as amoxicillin and Kiflex, that has great bioavailability too. That's over 80. It's a bit less, but still over 80% of bioavailability.
And often what we'll do for the beta-lactams is treat them at a higher dose, right? To try to maximize that pharmacokinetic, pharmacodynamic variable there.
Thank you. There's also a couple of questions here based on kind of, when's your oral fail and when do you change? And then also the length of time for treatment. So, one of the things that I'll often do is trend the CRP as a kind of a marker whether I'm getting on top of the infection with a combination of surgery and antibiotic, whether it be IV or oral. And then I always like to see the kind of CRP back to normal before stopping antibiotics of any kind. That's just my personal kind of way that I've been dealing with that. Is there any comments on, is that the right thing to do? Is that the wrong thing to do? Or is there specific timelines that are more preferred way of defining how long patients should be on antibiotics for?
So in terms of durations of therapy, I think probably the newest data we have is from a study called the DTIPO study. This was published a few years ago in New England. That was a non-inferiority study comparing 6 versus 12 weeks of therapy for prosthetic joint infections. This was based out of France. And essentially comparing 6 versus 12, they weren't able to show that 6 was non-inferior to 12 weeks of therapy. And so the treatment failure rate in the 6-week group was around 18%, and within the 12-week group was around 9%. So it wasn't able to meet that 10% non-inferiority margin that they had pre-specified. And so I think the bottom line is I kind of take it case by case based on their response to therapy, how they're healing, and how they're doing. I do consider the CRP as one of the variables, but I wouldn't necessarily prolong therapy just based on a CRP value alone.
And depend of the pathogen identified too, because some will respond better to antibiotics such as streptococci or Cutibacterium species. Previously to DATIPO, we had IDSA guidelines recommended like secondary prophylaxis for 3 to 6 months after PJI infection secondary to staphylococci. So we're doing 6 weeks of IV and then transition to oral for 3 to 6 months. So with the DATIPO study, we could maybe shorten that to only 3 months total.
Okay. There's a question here. Maybe I'll target to George. What if with oral antibiotics there's no clinical response? Is it a high CRP? Is it wound drainage? What's your next steps?
I think I suspect we're talking about the sort of perioperative period, or maybe not the first few days, but later. Then it's a further workup whether this patient would need more surgery, and that is typically a discussion with our ID physicians, and of course reviewing the bacteriogram from the initial surgery. So again, start from scratch and see if you need to go back to the OR if ID has nothing else to add.
Would you take
sometimes a single surgery is not the end. You've just commented about the need of the Mayo group from Arizona having published a double dare. A large number of patients sometimes need to go back because they don't respond straight away. So the fact that they failed treatment doesn't mean that they have failed because of the oral antibiotics. They have failed treatment because they needed more surgery, greater debridement, perhaps no foreign material in that hip or knee in order for the biofilm not to be present. So there are more factors than just the oral antibiotics, in my opinion.
Okay. Do you think it's worth an antibiotic holiday before you take them back to the OR in that situation, or you don't think, or that doesn't make a difference if you're trying to kind of reculture another organism?
I think a patient who is in the hospital already, I'm not sure. We have stopped doing any antibiotics holidays. Obviously, we do the antibiotic holidays for outpatients, but not inpatients.
Okay, thank you.
Can I ask a question for orthos? Do you tend to do systematically a second look for Staph aureus infection? Like if you choose to do DARE for a patient and it's growing Staph aureus, do you systematically do another second look? No.
You mean a secondary? No.
No.
No, with a DARE is fine if you've got a really sensitive antibiotic and it's an acute presentation, especially post-surgery. Anything beyond that, I think you're looking at an explant. I think one thing I've learned over the years is you've got to be really aggressive surgically if you're going to get on top of these infections. And I think that's why, the take-home message is that a lot of arthroplasty surgeons that deal with this more regularly and know how to take these implants out and put in spacers are the ones that should ideally be dealing with it, not a trauma surgeon or an upper limb surgeon that's covering call. There's lots of questions here that we could kind of go on all night, but this webinar was actually scheduled for an hour. So I think we should probably try and draw this evening to a conclusion. So first of all, I'd just like to do a special thanks to tonight's speakers and all those in our associations who've worked tirelessly in the background and helped support and put this together this evening. Thank you to everyone who's registered and joined us tonight. I hope you found the session informative, that you've learned something new and to take away and perhaps change your thoughts or your management on periprosthetic joint infection. Maybe you knew it all and this was a way of just kind of confirming what your practice was, that you're doing the right thing. Either way, I hope it was informative. I certainly encourage everyone to try and provide some feedback to us through the links that are provided, and you'll receive your certificate of attendance. I don't know if I want to make a shout out to Dr. Phil Lamb, who has worked tirelessly and put a lot of effort into tonight's webinar, and I put a special thanks out to Dr. Lamb. Thank you.